Hello and welcome again to the AABIP podcast. With Dr. Kyle Hogarth from the University of Chicago, we are discussing expanded criteria for BLVR and bronchial thermoplasty. If you have not seen the BLVR section, please check it out at episode 31A. This is episode 31B, where we will only be discussing bronchial thermoplasty. Dr. Hogarth, thank you so much for your time again.
No problem, Udit. I'm sorry that we had to split it in half, but you know me, dude. You gave me an open forum. I'm going to just ramble on and on.
This is very helpful. So let's talk about bronchial thermoplasty. So most studies basically demonstrate benefit in patients who have a relatively well-preserved FEV1. And most patients that get referred to me have an FEV1 of like 20 to 40%.
Of course.
So how do I approach these patients differently from those who have been included in the trials?
When we first started doing bronchial thermoplasty clinically, the very first person I ever did as a clinical case, as opposed to the research components, did not remotely meet the criteria for the AIR2 study. I guess the argument and the thought process that we had from our perspective was, and why we agreed to do thermoplasty in someone who, this wasn't on label or off label. It's not a labeling question. It wasn't just where's the research, right? And are you comfortable, with doing someone this sick? At least sickness being measured by FEV1. And our answer simply was yes, because these folks needed somebody to obviously help them, but also an issue of, we work very closely with our anesthesiologists. The thought process is that we have a stable disease. They're chronically obstructed, but we do bronchoscopy on lots of people with advanced lung disease. For cancer diagnostics and other therapeutics. Why should this be any different? The safety data on people with higher FEV1s was profound in regards to lung function and postoperative care, et cetera. This is again a quote sick group, but this was a group that we felt comfortable doing. Now, I will admit our first couple of cases that were sicker than what would be considered acceptable for the AIR2 trial were all people that never had a history of intubation at the time. But low FEV1 to us was not a reason to say no. And just again, since you said we can talk some evidence on things, but then let's talk about just the sort of anecdotal experience of life. The first lady we ever did had an FEV1 of 33% of predicted, had been on steroids 6 times a year on average. We did her bronchial thermoplasty. Her airways were ridiculously chronically remodeled using a simple diagnostic-sized scope. We had actually trouble seeing subsegments of the lower lobe. We could obviously see each segment, but to actually visualize subsegments was challenging. And that's with some pretty significant pushing against the airways, et cetera, to try to get your scope in. Anyway, she, after her third thermoplasty, we saw her, in clinic, and she already was commenting about a better ability to breathe, just in the sense of her day-to-day FEV1. And for what it's worth, it was now 40% of predicted in our clinic. But when I last saw her in follow-up, which was 3 years ago, I'm not her primary, pulmonary doctor, and she had actually come in for a separate issue. Since thermoplasty, she had been on prednisone once. So this was 6 times a year and to once. And the one time was when she had influenza. So pretty darn good reason. We published then our case series and presented it also at the ATS meeting years ago of our first 10 patients who were all very severe, all who were past criteria for AIR2. That's also been put together with several other centers who have done this, who took the idea of, there are plenty of patients who don't fit AIR2 criteria, have had a history of intubation, have had, chronic prednisone use or frequent exacerbations, et cetera. And so not just our center, several other centers have taken this approach of there's not really a specific exclusion with I'll go through our workup in a minute, but not a specific exclusion per se. And we've been able to, one, safely carry all these people through, which I think is the first and only question that really needs to be answered, which is, can you do this procedure safely in these advanced diseased patients? And the answer is yes. The data supports that as well. And not just our center, but several centers. Now, clinical efficacy is variable, just like you saw in AIR2. There is obviously a non-response rate, so it's not, a foregone conclusion of response, which is not dissimilar for what that's worth. So I'm going to ask you, did you do BT on that patient?
No, this is hypothetical, but yeah,
okay.
all the BT cases I've done so far at Mount Sinai have been on patients who would not meet AIR2 criteria. So all of them have been severe in terms of
quote, too sick, right?
Yeah, too sick, exactly.
And let me ask you, so you've done BT on those folks. How did they do? Not their outcome, like clinically, that's a separate question. How did they do from a safety perspective? Did you have anybody get intubated?
No issues so far.
Exactly.
But this is a small sample size, but no issues so far.
Of course, no, small sample size. But our center and then several other centers have, and I was trying to find the reference. I know we presented it as an abstract, but my brain is not firing on all cylinders right now to be able to find the reference for the paper. But there were essentially 100+ patients across 4 centers who all had met one exclusion criteria from AIR2 in the sense of, FEV1 or history of intubations or exacerbations. And the outcomes were similar to what's been seen in other studies. So I think that's the other key thing, is that we're not, you're not seeing it be futile in the sense of, there's a 20% response rate or whatever. But also, I think also is equally important that, like I said at the beginning, safety, because that's what matters the most. If you're going to try to deviate from what would have been considered the limits to the trials, you better know that you're not harming people, obviously.
So my next question is basically partly already answered by you. So one of the biggest benefits is exacerbation mitigation, right? And one of the relative contraindications is frequent exacerbations in the last year.
Right, so, which seems kind of funny, right?
Exactly. So in your practice, how frequent is frequent, and how far from the last exacerbation must they be prior to performing the procedure?
No, that's a great question. So I will tell you this. If you are coming to do thermoplasty with me, and I need you at least to be at your relative baseline, and whatever that is, they may not be that great. But if you're scheduled for BT this week and you call and say, I just got started on, 40 of prednisone because I've got an upper respiratory infection and I'm starting an exacerbation and I'm increasing my nebs, blah, 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 blah. We'll do you a month from now. And the whole argument there is, of course, one, this is an elective procedure. So, there's no emergency thermoplasty. So I don't, if you're not breathing, if you're breathing worse than your baseline and your baseline is not good to begin with, but if you're breathing worse, I'm not touching you. I don't need to kick you while you're down. Right. What do you do about someone who's, never seems to get to, some level of a stable baseline? If that's the person who's, potentially a chronic prednisone user, that, every time they try to get weaned, they flare sort of phenomenon. They do the sawtooth prednisone dosing. Then we go for a chronic dose up front and carry them through to do the thermoplasty.
All right. So on those lines, BT is approved for adults. I have a 17-year-old who is otherwise a great candidate. So must I wait for another year, or is there some way I can get it done now?
What a great question. So far I have failed to be able to get the 3 people that I was asked to do who were between the ages of 15 and 17 approved by the insurance companies because, of course, they are, quote, children, even though physiologically they are obviously adults. We actually did one young woman on her 18th birthday was her first thermoplasty. Pretty crazy. And she did fantastic and has continued to do so. Her asthma is actually, we did her 10 years ago. And so, she's obviously very much an adult now. And is actually in healthcare, which is kind of fun. I think she got indirectly inspired to work in healthcare simply through, her own asthma experiences and then seeing what we could do for her. But, this is, this is not the forum to have a discussion on, what's considered an adult, and approval of devices for certain ages and whatnot. I've got my own opinions on that, but the indication is 18 and up, and there's already enough of an insurance problem to get approval for thermoplasty. To get any of them to go beyond that is a challenge. My center, we can do in our endoscopy area without any real issues, anyone down to 15, obviously with all the correct consents and permissions, not just thermoplasty, just procedures. Below 15, we have to do in the pediatric area, and it actually has everything more to do with that nobody in the adult endoscopy area is PAL certified.
So I know you have a large population of patients with asthma that you manage. And in your practice, are all patients with severe asthma with an atopic or eosinophilic phenotype considered for BT only after they've been considered for or failed treatment with a monoclonal?
That's a great question. So I don't run our severe asthma program directly. That is run by others. But frequently what happens is who have failed to improve or improve enough with a biologic. So, my referral base of pulmonologists and allergists will send me patients for BT because they tried the biologic first, whichever one, 413, 5, IgE, whatever. And either had a decent response, but not enough, and there's still too many exacerbations and so forth, or no response. As good as those drugs are, if you look at the data, there's clearly not a 100% response rate. And so they'll be referred for BT because obviously the primary thing failed. My approach in general has always been, I just want your asthma under control. So look, if you are a profoundly atopic patient, high eosinophil counts, and no one's ever tried a biologic, then something targeted, against IL-5, sort of has it makes an intuitive sense. And obviously you can have that discussion with your patient as well, in the sense of, thermoplasty versus a biologic. Some of that will also be dictated by their insurance. Certain insurance carriers will not cover thermoplasty, but will cover a biologic. And so, it doesn't matter what you're thinking, as a lot of modern medicine is these days. I think, or maybe a different way to answer your question is, I've had plenty of patients come to me who are on a biologic that objectively improved their asthma, but not to a level of control that is considered, good. So we added thermoplasty, and vice versa. I have done thermoplasty on patients who had a good response to it, had a large reduction in exacerbation frequency and severity of symptoms, but are still exacerbating. So the procedure worked by all measurements, but clearly not to what I want as far as total asthma control. And we have then added a biologic as another component to better control their asthma.
Got it. Okay, so my next question, which will be my last one, is maybe controversial. Hemoptysis is reported as a complication, right, of BT, but I'm yet to see that. On those lines, should dual antiplatelet therapy be a contraindication?
What a great question. So the hemoptysis from bronchial thermoplasty, some of it is just that, some of these folks have relatively friable airways as a component of their disease. And as smooth, the catheters have got a, smooth blunt tip, and the metal component that's touching the airways is smooth. But you're sliding it in and out. Sometimes if you're working with one of your fellows, they might push it in a little harder than they should, et cetera. Minor airway trauma can occur. My first thought when someone comes to me and says, I'm on dual antiplatelet therapy, and my asthma's out of control, my first question is one, are you actually having problems with your asthma, or is this another marker of is this your anginal equivalent? Because I'm assuming you're on dual antiplatelets because you've got cardiac stents. So the first real question is, I need a real cardiac evaluation and an update. I get my cardiologist says my stents are fine, and you find out the last stress test was 3 years ago, and they've been getting progressively more dyspneic, and et cetera. Right? We've all been there, and so you say, look, let's get you cathed, and lo and behold, of course, you discover that it wasn't that they needed bronchial thermoplasty; they needed a new stent in their left main, their LAD. And so, backing that part off, maybe they're on antiplatelet for a different reason. But then that would also make me wonder, what disorder are they on antiplatelet therapy for that could be leading to pulmonary symptomatology? They've had a history of I don't even know. They've clotted and had a stroke or whatever. And, well, okay, what disorder led to that, and what other issues do they have going on? So it's easy for patients to have a slap-on label of asthma and be told they need bronchial thermoplasty. And in reality, what they don't even, our own referral pattern, thermoplasty, I would tell you that probably, I was looking last at the numbers, 1 out of 20 people sent to me with out-of-control asthma for bronchial thermoplasty, we've, during our workup, discovered don't even have asthma, like literally don't have asthma. So, be more than a procedure has always been the mantra for our profession. And this is, more proof of that. And then roughly 4 out of 20, we discover have not asthma as severe, but that we find an underlying other etiology that is aggravating their condition. And that when you control that condition, say there's some underlying bronchiectasis and a chronic infection, for example, and you control that, then lo and behold, their asthma goes back to being well controlled with, inhaled corticosteroids, LABA, et cetera. So in other words, you didn't need to start tucking even biologics or procedures. You just needed better asthma management and asthma definition of what's really wrong. But then, but still, a majority of the bad asthma that comes to us indeed does. They've had thoughtful workups and evaluations by pulmonologists and allergists, et cetera. But for sure, I don't just do thermoplasty because you ask.
So again, but in terms of the bleeding risk, do you think there's an increased bleeding risk on someone who's taking dual antiplatelet therapy and you decide to proceed?
Oh, there probably is. I can tell you we did thermoplasty on one person who continued on their clopidogrel, their Plavix, during the procedure, and there was no increased risk. They didn't bleed. So there's my, you said we're in an evidence-free zone. So there's my anecdote. And she, and we've also, same with also, not just antiplatelets, same with anticoagulants. So we did have a person who had a prior clot history and had been on warfarin. And needed to continue it, was uncomfortable with wanting to stop it. And so we continued through and did thermoplasty without issues. I obviously consented for bleeding and more bleeding. I mean, this is again a thoughtful discussion between physician and patient on what could be, occurring, what badness could happen, et cetera.
Kyle, thank you so much. These were tough questions. Thank you for being so meticulous and detailed with your answers. I think everyone's going to love this, and it's going to be useful for practice more than anything else.
No, I appreciate it. I think I'm glad you asked these kind of questions, Udit. I think, especially in as bronchoscopy has, more potential therapeutics entering into the space for airways-based diseases. Obviously, as you know, there's several trials ongoing of new devices. I think there's always going to need to be a thoughtful discussion of the ability to expand beyond trials that seem reasonable, ethical, and safe.
Thank you so much for your time again.
It's my pleasure. Happy Father's Day to you, Udit.
Likewise.